My name is Amandeep Gill. I'm the CEO of IDARE, the International Digital Health and AI Research Collaborative, based in Geneva, but with a growing network of hubs and partners across the globe in places as far away as South Africa, Chile, closer home to India, in Singapore, and so on. So we have an exciting and a serious subject to discuss today, but I have discovered in the last few minutes that though it's a serious subject, it's a very happy panel that we have. So we are going to enjoy ourselves. We'll have a good conversation and we'll get you in shortly. So here is the program. I'll say a few words to tell you about the panel, and then we'll call our first speaker, who will give us a keynote. She will set the tone for this discussion, and that's Mrs. Preeti Sudan, who is the former Health Secretary of India and a member of the WHO's independent review panel on pandemic preparedness and response. Sitting next to her is Mark Chataway, who heads HIDRIS, based in Ireland. I hope I pronounced it correctly. So he has years of experience in innovation, technology, health, working primarily with the private sector, and this is a multi-stakeholder issue. So I'm glad that Mark is here to bring a private sector perspective, among many other perspectives, to this discussion. And next to us, we have, next to him, is the distinguished Deputy Minister from South Africa. Welcome, ma'am. Yesterday you spoke about gender issues in a very clear and convincing manner. And today we hope to have you tell us about South Africa's experience on health, on technology, and on innovation. Next to Minister Dlamini is Ambassador Djalal, Dino Patti Djalal, who heads a think tank in Indonesia and was earlier Indonesia's ambassador to the United States. Indonesia is the current G20 president, to be followed by India and then later on by South Africa and Brazil. It's a very interesting constellation, confluence of chairs that we will dive into in a little bit from now. So before I give the floor to Mrs. Sudan for her keynote, let me just sketch out a few themes that we're going to explore in this panel. There is an unprecedented opportunity today with digital technologies to accelerate progress on the Sustainable Development Goals. Data and artificial intelligence can help quality health care in rural areas where specialist medical advice is often unavailable. And here I'll pause to introduce our panelist who's joining us virtually from Seattle, and that's Gargi Ghosh. Welcome, Gargi. I hope you can hear us. Gargi is president at the Gates Foundation, responsible for global policy and outreach. And she and I have had the pleasure of working with Melinda Gates, who was the co-chair of the UNSG's high-level panel on digital cooperation. It's very early for you, Gargi. I hope you have a coffee mug next to you. Really looking forward to, there you are, to your thoughts and your insights. Now, we were speaking about the digital opportunity in the health domain. So today we've seen how we can deliver quality healthcare at distance. This was so important during COVID times when regular access to health facilities was a challenge. Digital technologies can tailor interventions, nutritional interventions, for instance, for mothers, or combat misuse of antibiotics. And there are many, many more opportunities. During the COVID crisis, we've seen how AI can help with drug discovery. One of the treatments for COVID was possible only because millions of research papers could be read using AI and promising drugs shortlisted. It's also been a boon for managing the vaccine rollout. We couldn't have imagined 1.85 billion vaccine doses in India without the help of digital platforms like the CoWIN. But this is not an equal opportunity. And we were discussing just before our panel the deep inequities there are in connectivity, in access, but also in biological sciences and in access to health. So when these two inequities across health and digital come together, they create a concern for the future, which we need to address squarely now. Today in this panel, we will explore a third theme as well. So apart from the health and the technology dimensions, we would look at the diplomatic dimension. There is a need for countries, small states in particular of all income levels, as well as LMICs, large LMICs, low and middle income countries, who have the needs, who have the rising talent today. We've seen that with genomic sequencing in Africa, and who also have the drive and the motivation to leverage digital technologies responsibly and inclusively for accelerating progress on the SDGs. So that diplomatic dimension, I mentioned the G20 opportunity, but there is also small states of all income levels who've been digital pioneers, from Sweden and Israel to Rwanda and Singapore. And these are the countries who don't have their own large data sets, large multinationals in AI and in data, and therefore have an incentive to come together and work with countries from the global south to shape this field. So with that brief introduction to our panel and its themes, it's my great pleasure to invite Mrs. Preeti Sudan to deliver her keynote address.
Thank you, Ambassador Amandeep, Excellencies, Ambassadors, colleagues, ladies and gentlemen. It's a pleasure to be here, and I must say that the distinguished panel with whom I have been interacting informally will have lots to say for us to ponder and then take forward. Today's theme is digital doses, healthcare technology, and a coalition for the willing. So I would like to say at the very outset that pandemic has shown to the world that digital doses work. Digital technologies have been leveraged with varying degrees across the continuum of the pandemic phases. And these phases don't seem to end. We are now, again, the cases are rising all over the world. So let me just give you a few examples. I have handled it hands-on also. I'll try to keep the narrative global, but excuse me if I give in some examples of India's experience. So we used it in surveillance, alert, and contact tracing. There were apps, there was Bluetooth proximity technology, there was IT-enabled integrated hotspot analysis using artificial intelligence algorithms, GIS mapping, and of course, the analytics. And this is how India looked at it, and this is how many parts of the world also looked at it. And that's why, you see, we are where we are as far as COVID management is concerned. We couldn't have done public advice, community empowerment, tackling infodemic without technology. Information exchange between citizens and the system, feedback, helplines on mental helplines, hospital availability helpline, clinical management helpline for doctors handling COVID, because we in India had these centers of excellence where you could call up 24/7 to take advice from senior doctors. So it is only with technology that actually we could manage our patients somewhat better. And of course, opening war rooms, centralized aggregation of data from all stakeholders through portals, again through apps. Here I would like to emphasize on one point, that in India, as health secretary who initially handled COVID, one thing that struck me was, the benevolence of people, the benevolence of private sector, the benevolence of consultancy firms. I had people working pro bono for us, handling our war rooms, advising us on technology. So that was a heartwarming part. And that's what I feel gives us hope, gives hope to all the people who are here and all the people who see digital technologies as, as a great advantage, not only in terms of speed and scale, but also in terms of affordability. Then, of course, inventory management, sending essential supplies, PPEs, masks, then ventilators, only managed with technology. And here again, the private sector, the laboratory networks, the manufacturing hubs, how they came together, because India suddenly, with your millions of population, and suddenly we found we don't have the cloth for making PPEs. We import it from China. What do? We don't have the respirator for N95 mask. We import it. We don't have test and probes for RT-PCR test kit. We import it. And today, I'd like to say with gratitude and with, I would say, great pride, that we export these items was possible only because of very, very trusting partnerships. I use the word trust because it is only trust that can take us forward in digital technologies also. I'd like to mention just one line on the Vaccine Intelligence Network. Ambassador Amandeep mentioned about CoWIN. So the CoWIN is I would say, a higher adaptation of what we had for our vaccine management even. It's basically a vaccine intelligence network. And you see each dose tracked from supply to the vaccinated. Millions vaccinated, but we know who, where, how, which vaccine. So that's the beauty of technology. And then tackling supply constraints through manufacturers, I already spoke about. Then telemedicine as a viable tool. It emerged during the COVID days. There was isolation. The doctors were very busy in, ICUs, in isolation centers. What do we do? So to tackle the shortage of specialists in an affordable manner, to actualize timely clinical pathways for regular follow-up post-hospitalization and so on, telemedicine now stands rooted in India, and I'm sure in all parts of the world. It has shown its usefulness and merit. So friends, we have billions of mobile phones, large online data sets, connected devices, wearables, relatively low-cost computing resources, and advances in machine learning, artificial intelligence. The stage is set for a digital health revolution. Now is the time. And it's already underway. Startups are coming up with innovative and affordable innovations. They need to be encouraged. I just want to mention EmiTag, a real-time monitoring of ambient temperature during transportation of perishable products, vaccines, body parts, blood, which has been done with the help of our Indian Institute of Technology in Ropar in Punjab. Why I am mentioning it? Because we need academia, we need researchers, we need manufacturers, we need consulting firms, and we need government as a facilitator. That's the way forward. There are issues. This pandemic has exposed inequities of resources, of information sharing, of essential supplies, of availability of vaccines. We have seen pre-ordering and hoarding by the West. There is digital divide with gender overtones due to limited devices in the family, also due to connectivity issues. then another point is that we are dealing with people's health and lives. It's not just technology and data privacy, consent framework, grievances redressal mechanism. These have to be at the heart of any policy and interventions. We must remember health systems are multi-layered. Primary, secondary, tertiary, public, private, charitable, the different systems of medicine, traditional, modern, and then wellness in health. I think very, very important, because that's what India is now emphasizing, especially when we are embarking upon our journey of universal health coverage. Wellness, our health and wellness centers is one way we are institutionalizing, and integrating our wellness paradigm with Eat Right, with Fit India, with, integrated solutions. So these nuances need to be understood, and the solutions need to be contextualized. That's very important, and that's true for the world. So context is also important. Well, having raised these issues, I would say there are opportunities. Digital health is a global good, let's acknowledge it. The independent panel for preparedness and response, of which I was a member, and also the G20 high-level panel, we actually had sessions together also, have emphasized this. Global health governance needs an overall. Can, as today's theme suggests, a coalition of the willing make a difference? I'd like to add, let it be a coalition of willing equals. Who are these in the field of digital health? I would name G20, the Global Digital Health Partnership. India headed it for a year. I presided over it. The largest intergovernmental partnership on the issue. International bodies like IDIRE, which are led by Amandeep, private sector, academia, startups. Can they come under one umbrella, facilitated by WHO? The approach has to be One Health. The MOU of WHO, OIE, FAO, UNEP has to actualize into an integrated system of alerts for the world. In fact, you are maybe aware that out of 10 diseases listed by WHO as likely epidemics, 6 are zoonotic. So while WHO gets its act together, can the regional formations show the way? Can the upcoming G20 summit under the presidency of Indonesia, with 3 broad priorities of global health architecture, digital transformation, and sustainable energy transitions, really help the world recover together, recover stronger? This is the theme that they have chosen, very relevant. And with India taking over the presidency next, can it consolidate the initiative and make health, and digital health in particular, a true global good? The experience of COVID and Ayushman Bharat Digital Health Mission, now made pan-India, with data security, patient consent, accountability at its core, these learnings can really, really help the world. So best practices exchange is also very important, regionally and across the world. And of course, another opportunity is that technology can be the bridge for integrated medicine, modern and traditional, health and wellness. What do we need urgently? According to me, we need urgently an international regulatory framework for digital health, stronger international data security protocols, and an unwavering commitment to open source systems and softwares. Nationally, the entire spectrum of healthcare will need digital workforce enablement and process reorientation. Primary, secondary, tertiary, preventive, promotive, curative, subnational, local, across all health professionals, including frontline workers. And let me tell you that we used technology for training our frontline workers, our doctors, our nurses. Frontline workers did not know how to wear a PPE, how to dispose it off, how to reuse it. So we created a portal called IGOT, Integrated online training, and when we trained volunteers also, because lots of people came to help. And this needs to be taken forward. So as far as India is concerned, I would say that to some extent this enablement has taken place, but it would need consolidation, and India should help the world do it, and especially this region. Of course, sharing best practices and empowering communities, please remember communities, through dialogue and information is critical, because they need to be confident. They need to be very, very, I would say, assured that technology is to be trusted. It will not, they will not be exploited. I'm sure this August panel will throw light on these and many more relevant issues. I look forward to the deliberations. Thank you.
You covered a lot of ground. You've given us a comprehensive background. You've given us an agenda, in fact. And some of the points that you mentioned about different stakeholders coming together, the importance of trust, looking at digital technologies as public goods. So perhaps we can dive right in. And I was wondering, Gargi, if you're ready, if you want to come in at this stage and give us a perspective from the Gates Foundation. You've helped the world treat vaccines as global public goods in modern ways. And with the digital side of things, there's been the high-level panel, but many other initiatives where you've led. So how do you see this from the global perspective, particularly where, insofar as philanthropic organizations are concerned?
Well, thanks, Amandeep, and thanks, everyone. It's a pleasure to be joining you. I wish it was in person, but I unfortunately came down with COVID last week, so was unable to travel. So the topic feels very live. Thanks for having me. So I would maybe start with exactly where our opening speaker did. From our perspective, the acceleration in development of medical interventions has been profound and possibly among the more life-changing aspects of COVID and COVID response. Just to put some specifics on it, prior to a COVID vaccine, we saw a typical timeline from microbe isolation to approval of a vaccine more around 4 decades, 40 plus years. And the fastest prior, really around 4 years. I was at an event yesterday evening with President Johnson Sirleaf, former president of Liberia, who talked about Ebola in the 60s in DRC and not having a vaccine several decades later. And to contrast with COVID, it was 11 months from microbe isolation to widespread development and coverage. Of course, coverage was not equitable, it was not fair, and that forces us to confront the incredibly important point of access. Let me stay on technology and then access for a minute. So on the technology front, I think, whether it's virus exposure, digital medical consultation, online pharmacies, there are a number of ways in which across the globe, the COVID experience with technology will transform basic healthcare. It is certainly transforming the scientific development, the innovation aspect of healthcare. We have been, as a philanthropy, it's been our pleasure to support almost 20 companies across the developing world to bring new technologies to market. We've helped bring 17 new vaccines to market over the past decades, and that has been a profound honor on our side, a contribution to global health. I hope that new technologies, mRNA technology, Of course, we are optimistic that India's great capabilities in vaccine development and manufacturing will be part of continue to be part of the story of vaccine production and supply for the globe. I do want to spend a moment on access, though, because, of course, the best technologies, the best digital platforms do still require a concerted policy effort, policy intervention to reach the poorest. Indeed, this is some of the work that Melinda Gates, Strive, the UN system, focused on in digital pathways. How do we build the digital ecosystem to ensure as something as seemingly simple as women having access to mobile phones, digital technology, so that the distribution channels are established and fair. I would also note, as we focus on healthcare here, the COVID experience also reminded us that some of the basic digital rails, digital payments in particular, outside of the narrow health sector scope, were actually critical in protecting lives and livelihoods. We saw over and over again that countries that had established strong digital rails, India among them, to provide access to payments, helped particularly the most vulnerable through the COVID sort of lockdown and constrained period. So the kind of broad conception of the role of innovation and digital combined with an equally strong commitment to access is what we're hoping to see. We have a small part to play in that, but are looking forward, of course, to continuing to partner with not just governments, but private sector in India, Indonesia, and beyond. Thanks.
Thank you so much, Gargi, for those opening remarks. And we'll come back to you, pick up on some of the points that you mentioned, and perhaps coming back to access issues, inclusion issues broadly. But maybe I can turn to you now, Mark. You've heard a perspective from the philanthropic sector. You've heard a government perspective, the private sector. So what role can the private sector play? And what Mrs. Sudan said, that was heartwarming. So can that be universally tried?
Well, so yes, I work for a consultancy company, and we do work for public sectors and government too, but most of our clients are international pharmaceutical companies, or international pharmaceutical devices companies. So I think what Mrs. Sudan said was the heartwarming bit. Let me give the frightening bit. So she can play the good guy, I'll play the bad guy. Disruption is always terrifying, right? And the disruption that's going to come over the next 15, 20 years will terrify everybody, including the private sector. But actually, I think they'll be the least frightened. We're moving from this focus on intellectual property, which obsesses everybody, into an era of big data. And so it won't be possible for anybody to have exclusive ownership of the data sets that are going to determine the patterns of treatment. And Mrs. Sudan mentioned this in terms of, or one of you mentioned it in terms of antimicrobial resistance, but it's true in terms of cancer, it's true in terms of cardiovascular disease, that diagnosis and treatment will be linked to massive genomic databases. So that when I present with a cancer, they're going to say, we know this is his health history, we know this is his genetic profile, we know this is the genomic profile of his tumor, and we have a database of 20 million people, and we can find 300 or 400 people who are just like Mark, and we know therefore how to treat him. So that's not something one company is ever going to own. So companies have to figure out how to be part of a collaborative ecosystem in which this data can inform their drug development, their treatment programs. And that will be frightening, but much more frightening for the healthcare professionals and for the health systems. Because Mrs. Sudan mentioned some of the benefits. Let me talk about what if you have AI in AMR, if you have an AI system which says the chances are that Amandeep is presenting with this pathogen and the chances are that it's resistant to these drugs, that's wonderful. It improves your prospect of recovery. It sort of marginalizes the doctor a bit, because what does the doctor have to do? Authorize a digital prescription. Do you need a doctor to authorize a digital prescription? Probably not. The AI can probably do that as well. Of course, I'm not suggesting there's no role for doctors, but it'll be a different role. And so I think it's more a coalition of the nervous than a coalition of the willing. We all have to try and manage our insecurities so that we don't put barriers in the way of technology. We embrace it and we allow it to go at full speed. And my final thought, and I'll shut up, is that I think this is much more likely to happen in middle-income countries than in high-income countries. Because if you're an oncologist in Indonesia, you're not worried about being put out of work. It's a remote prospect. If you're an oncologist in the United States and you're not a professor at Harvard or Hopkins, you should be quite worried about being put out of work. So I think these innovations, these digital innovations, are going to be embraced in middle-income countries far faster because there are fewer vested interests to, even unconsciously, put the brake on than there are in high-income countries. So I suspect that those of us in Europe and in North America will be looking to Kenya, will be looking to India, will be looking to South Africa for examples of technology being implemented. Some of it will fail, some of it will succeed, but things we will adopt. So I think there'll be a two-way learning. No doubt drug discovery, no doubt the sorts of technology hubs you're talking about, Singapore, Switzerland, will continue to need to share skills with middle-income countries, but middle-income countries will have this reservoir of data and of skills to share back to high-income countries. And it's worth remembering that as humanity spread out of Africa, we lost our genetic diversity. So that in this era in which genetic diversity is so important, Africans become an extraordinary resource for the world because the genetic diversity of humanity is at its fullest in Africa. So I think it's another reason for everybody to think the world will be turned upside down, but probably in a mostly good way. So I hope I wasn't too frightening.
No. If the audience agrees, we can change coalition of the willing to coalition of the nervously willing. Thanks, Mark. and that's a great point about the shift from IP to big data. And that's what the private sector needs to start thinking about right now. Some have already started that. So they would need other ways rather than CSR or some other existing arrangements to incentivize that kind of data pooling that would be required in the future. But we'll come back to this point about a collaborative ecosystem, which I think all three of you who've spoken so far have mentioned in one form or the other. Madam Minister, turning to you now, please give us a perspective from South Africa.
Thank you very much. This is the taste of the developing country. Well, health technology, it's really something that is a public good, as other speakers have indicated. In South Africa, we have adopted the legislation on national health insurance because we are aware that it is very difficult to switch on technology and not funding the technology that is needed, especially South Africa. As population, it's so skewed. It's 60% rural and 40% people in the urban areas. So we felt that we need to reach more people that are in rural areas. But our environmental terrain in South Africa, it's so difficult that even the signal you can't get in other areas, which means that the infrastructure like electricity and telecommunication, it's very important so that it can be installed in those parts of our country to make sure that they access the health technology and health information. In South Africa, people that are more disadvantaged in terms of the ICT technology and the rest are women. Because, you know, in the rural areas, we have got serious problem that women don't have cell phones. We have a program in our government that chronic and HIV medication, we need to communicate, not people just to come to hospital and collect, but you can just send a message to them. But it becomes so difficult in some of the terrain that we can't reach them. But you need to hire people physically to go house to house and deliver chronic medicine, which is a very difficult thing. So I hope this forum will help me and help us and help my country with ideas how to deal with that particular initiative. Investment in technology is something that we are looking at as a country, in view that the fiber that we are speaking about for people to access information is not in all corners of our country. So it means there must be some extension of the infrastructure for us really to make sure that we access our medication. Of course, the National Health Insurance is coming a little bit handy for medication and also to access specialists, because in South Africa, like the latter speaker has just indicated, if you need an oncology doctor, it's a scarce skill in our country. So if really we're using telemedicine, then we can access an oncology anywhere, and we can even share the few oncology doctors that are in the country so that they can really start to reach the different parts of our areas and our community access the health services. Well, we're looking forward for this meeting to really make sure that as we discuss and as innovatives in technology goes up and be improved, let's not forget the rural people, the women that does not have a cell phone. A cell phone in a family, it's just one cell phone. And a signal in that family is ready to go up the mountain so that you can speak to somebody. So how do we really make that particular person to access the health technology in that situation? Help us. We're here to learn. Thank you.
Thank you very much. Thank you very much, Minister, for those remarks. So no one gets left behind. That should be our guiding principle. Access for all, benefits for all. Ambassador. So Indonesia is in the hot seat this year. So G20, we know there are some geopolitical challenges. Hopefully, we would be in a better situation by the time we get to the Jakarta summit. You've set out very, very clear priorities. Priorities, as you see, are resonating across the globe, those three pillars of Indonesia's presidency. So whether it's the nervously willing or confidently willing, so do you see an opportunity under Indonesia's leadership to do something innovative, different this year?
Oh, thank you. And first, thank you for inviting me here. And I want to say that table one there is eating all our food. Yeah, please. So please leave me some. Right. Those are the food for the panelists, by the way. I don't. You didn't know that. So, before I answer the G20 part, I just want to make some comments on that were made previously. First, in Indonesia, we are discovering that technology and health can do pretty big things. We have this app now for people to register their vaccine and trace where they go. It's called Peduli Lindungi, similar to what they have in Singapore and other places. But this is the first time for Indonesia to have a nationwide health app that has never been there before. And for us, you have to remember our national psychology. You know, Indonesia, fourth largest country in the world, 270 million people, 17,000 islands, right? So having a system that can deliver health service to people in faraway places is very much a challenge. And having this app, for example, is giving people a lot of ideas. And I think we're only seeing the tip of the iceberg, because once you have this app, once everybody has it, because we have about 70% internet penetration in Indonesia, 190 million internet users. Everybody has a cell phone. I have only one cell phone, but I have a household staff. My maid has 2 cell phones, right? And their mothers have 2 cell phones back in the village and so on. So the infrastructure is there. But the question is, how do we connect the dots? And how do we harness all this technological possibility to create a game-changing landscape? And I say this is not something to be taken for granted, because remember internet and email. You know, I became acquainted with internet and email in 1990, my first email address, right? And I was thinking, what if the whole of Indonesia, the villages have internet access? And I thought this would be an explosion of creativity and productivity if villages throughout Indonesia would have this access. And guess what? They do have it, but it's not leading to any explosion of productivity and creativity, right? So there is something missing there. I don't know what it is, right? But it's not something that we take for granted. So even if we have this technology and we have this infrastructure, it doesn't necessarily lead to a better health service system. And to a point mentioned by Mark, I like your point that the possibility of AI providing answers to people who are sick, yeah, and so on. I want to go in that direction, but the problem will be political, Mark, because Indonesian doctors are enormously egotistical, right? Especially when it comes to losing their income, right? We have many examples where things become digitized or open to foreign competition or becomes easier and so on. There are always strong resistance. Yeah, probably in South Africa too. Yes, there you go. Right. So unfortunately, we will need to strike a balance between what is best to provide, to use AI for the needs of people who are sick, and I love that. But we will need to be prepared for the political and social resistance from those who have benefited from the old systems. Right? Now, from the G20, you're right, it's a challenge. When we took on the chairmanship, Russia did not tell us that they were going to invade Ukraine, right? So, and things got really messy afterward. The G7 have threatened not to attend if Russia is invited. And BRICS remain consistent that they do not want to disinvite Russia. And then you have other countries in between whose positions are varied. But what Indonesia wants is for the G20 not to evolve into G19 or G13. We want G20 to become G20. And resolve many of the world issues because we are still facing pandemic issues, climate issues, economic recovery issues, and so on. But what the formula will be, we'll see. I mean, I think there is possibility that the formula of plus Ukraine will be accepted, right? Because that's what Biden has said. You know, I don't want to come if Putin comes, but if he comes, at least Ukraine must be invited. I think, the government has not made a decision yet. We're open very much to that idea. Health will be one key priority for Indonesia. We will continue with the program of creating a task force between the finance minister and health ministers. And there's this idea of the financial intermediary fund, which is to provide funds for PPR, a pandemic prepared response, that will be housed under the World Bank. Yeah, so we are very much in support of that, and we'll seek to make that happen. President Jokowi has come up with an idea of something similar to IMF for health, meaning countries that would pool their funds and to provide for countries that are in need in terms of health crisis. So that remains in progress. We keep pushing it, but some other countries have said, look, we sort of have that mechanism and so on and so on. So it remains a work in progress. Mark said something earlier about genomics database, and we're very much pushing that process. We want to optimize the global genomic data sharing platform that hopefully will be one of the results of the Indonesia's G20 presidency. We also want to push for a system whereby there is harmonization of COVID-19 vaccine certificates, right? So if you are vaccinated, you go to different airports anywhere, you are recognized, and you can pass through, right? So I think that will be important to keep the balance between controlling the pandemic and also recovering the world economy. And finally, we are very much in favor of diversifying the production, manufacturing hub of vaccines, because at the moment it's limited to only a few select countries, and we know that not every country can produce, manufacture vaccines, but at least in regions there should be hubs. So, for example, Indonesia has said, hey, for Southeast Asia region, Indonesia will be very willing to turn our country into manufacturing hubs for vaccine production. Yeah. So those are some of the things that we'd like to achieve for G20, and we hope that there will be still a G20, not G19 or G13, and we hope that the substantive part of it, despite of whoever comes on or miss the event, the substantive part will be delivered during our presidency.
Excellent. Thank you very much. You talking about the genomics platform is actually GIZAID, which helped us get off to a quick start on vaccines. All the genomic sequences of the SARS-CoV-2 virus have been uploaded there. We've been able to identify variants of concern quickly, and it actually goes back to Indonesia. And so look forward to another innovative or several innovative breakthrough initiatives coming out of the Indonesian presidency. So we've had an excellent first round. Maybe it's time to take in a few questions and go back to the panel. There are many themes that we can explore. There is the workforce theme that I want to focus on, and the inclusiveness theme as well, and the coalition building aspect. But maybe I see a couple of hands at the back. So, sir, you go first.
Hi everyone. It's just to share an idea with Candith about
Can you come up and grab this mic? Oh, yeah, there comes the mic. So Gargi can hear you as well.
I'm Dominic.
Just keep it brief.
Brief, yeah. I'm Dominic from Ivory Coast, and I'm based in Ghana, working with Robert Bosch on digitization. To share an idea with the South African situation, I would say I've seen an example in Rwanda and in Nairobi, in Kenya, in rural areas, where they could deliver drugs for the people in the village through drones. So they have a spot in the village with a certain time and date where the drugs are delivered. And then, due to access to technology, they are using very basic technologies like GSM, SMS in local languages to the women, so they shared phone for like 300 rands approx. They deliver to the mummies in the village, and they receive SMS. Today, it's your turn to go to that point and pick your drugs. And they get it like that. And then when it comes to video conference with a doctor, with a specialist, that's more complicated. But the easier solution is, as I know South Africa, kind of, you have like hospitals, like a regional hospital or big hospital in small villages, yeah? So they can go and consult on a specific date, Microsoft Teams, because this hospital will have internet and TVs, ETCs, but we cannot do that at home because smartphone is a problem. But they can converge to this hospital on a certain date and be able to consult a doctor. We reduce complexity and we deal with what we have. That's an idea.
Thank you for bringing those examples.
Can I just add to that? Actually, we in Indonesia are interested to find vaccines that are one shot instead of two shots. I know there are some who are developing that. And then vaccines that doesn't require minus 70-degree refrigeration, that you can keep in normal refrigeration, right? I know there are a couple of candidates for that, but once that are out there, things are become a lot easier, because if you give vaccines to poor people and ask them to come back a month after, a lot of them will miss that 1 month due date, right? So having a one-shot vaccine instead of two shots, and the one that can keep in a normal refrigerator, I think would be much.
Indian vaccines.
Please go ahead. Please take the mic. Yes.
So Indian vaccines you can keep under normal refrigeration.
Send some to Indonesia, please.
We will.
I just wanted to pick up quickly on something Dominique said. This idea of sort of health kiosks, local health kiosks where you can plug in to telemedicine networks, is of course something that India has been doing in remote areas of West Bengal. And it's a great example. So India's got this system set up. There are people, basic skills in the community who can, the doctor says, can you feel his arm, please tell me, whatever. They're trained to do that. That's what they do. That system has now been imported to the United States. The first health kiosk opened in St. Louis, Missouri, in a poor neighborhood, underserved by doctors. So it's a prime example of that transfer of skills from India to St. Louis. So, yeah.
Excellent. And I want to be careful about not diving too much into specific solutions, but staying with this broader idea that where there is, they say necessity is the mother of invention. So where you have the sweet spot between need and maturity levels, that's where innovation is happening. And we need to have that coalition among those countries to drive this whole system forward. We'll take a quick comment from back there, number 8. Yes, please. The lady at the back. Can you pass the mic back to the lady? We'll give that table a chance as well. Thank you.
Yes, thank you. My name is Clara. I work for the ICRC, the International Committee of the Red Cross. My question was in relation to big data sets that you were speaking about, and you spoke about how there'll be factors like your genome, like all of that. But then on the other side, we also know that things like whether the patient has a positive outlook or not make a difference. Whether your doctor takes you seriously or not. So how do you go about factoring that into those data sets? And then maybe if I can, and you don't have to answer because I'm only allowed one question, but you alluded to this already, but maybe there is something more that you can say about how we can leverage AI and data to show the shortcomings. So, for example, you spoke about this app this portal that you can use to look at how do you wear PPE. Very often, in my experience, it's also hard to motivate people to learn about this and do this if they make $2 a month. So maybe there are ways in which this can be more powerfully shown where the sort of soft component gaps and needs are, so that stronger advocacy can be built for those. I don't know. So thank you very much.
Thank you. Anyone wants to Yes, please.
So I think you raised very relevant points. One thing that I said was that context is very important, number one. Secondly, I also said that we are dealing with people's lives. So therefore, patient trust, patient-centric solutions are important. And it has to be a hybrid model. Because you see, when a patient goes to a known doctor, the very fact when he or she tells the patient, oh, you will be fine, it makes a lot of difference. So therefore, I don't agree with Mark that our doctors will go out of job. No, they'll do their job better. And that's how the private sector should also look at it. It has to be a collaborative. We're not substituting anything. We are facilitating. Because technology can work only with human interface, actually making it contextual, making it humane, and also ensure that there is accountability. Because you see, it's faceless. The patient needs to ask questions. The patient needs answers. The patient needs accountability. So therefore, when I see future of digital health in India and across the world, it is a system that works with the health professionals, does not replace them. It cannot. Thank you.
So radiologists won't be replaced by AI, but radiologists with AI will replace radiologists, as they say. Maybe one last question or comment. Maybe if you keep it brief, then we can make it two.
Sure.
And then I want to give the panel members a chance to, in their closing remarks, to address a few points.
Sure. Kia ora, namaste. My name is Gaurav Sharma. I'm a member of Parliament from New Zealand. I'm also a physician and I sit on the Health Select Committee in New Zealand. I've just got a quick comment and a question. So the comment is, when I was working as a doctor, it was really interesting to see COVID because in a way it was an equalizer. You're rich, you're poor, wherever you sit in the society, it affected everybody. But the difference, we were talking about social inequities, was that if you were rich and you had an 8-acre plot, you never felt like you were isolating from the world because you were raising your horses and doing your gardening. But if you're poor and there were 5 people in a room, it was obviously affected people differently. So obviously those social inequities are very ingrained. And that digital transformation obviously helps. But the question is, recently the biggest hospital in our country, which is in my electorate, actually got attacked, cyber attack. And we've been dealing with the consequences of that. My question is, with the digital transformation we're talking about and digital health, how much of that would become a problem, especially now that we're looking at state-sponsored, cyber attacks?
I can address it. Thank you for that question. So it's becoming a huge problem. We've seen this in Singapore, in UK, many other places. ICRC, other humanitarian organizations have become victims of these attacks. So we have to build the capacity. We have to build security by design. There's a lot of research needed in next generation, privacy preserving, secure federated computing type of technologies. So this will require massive investments. It'll require a culture shift across the health systems. So looking at the time, maybe one last question. The lady over there, table number 3.
Hi everyone. So thanks a lot for a very interesting conversation. I had just one question, which is that in all the examples that we have heard so far in the countries that have been alluded to, there are inequalities that exist at the get-go. And a lot of these inequalities, whether they're gender inequities or they're socio-economic in nature, they are a result of norms, they are a result of culture that is handed from generation to generation. And these things are very hard to shift. Now, when we talk about technology, and Dr. Sudan also referred to the gender overtones, the question is that it's almost like the technology is going really fast, but then you also have these underlying norms that are not necessarily changing at the same pace. So you almost seem like there's going to be a clash sometime, and that will lead to some people not getting what they deserve to get. So the last mile problem, we can fix it with technology to an extent, but we also cannot fix it without talking about these underlying norms. So my question is, when we are talking about this willing coalition, what is the lens that we are bringing to a very intentional approach, that intentionality that is very important to make sure that the technology, again, doesn't leave people behind? So I'll stop.
That's an excellent, excellent point. And maybe, Madam Minister, you can add a few thoughts here. Essentially, the principle is transdisciplinarity, so it cannot be technology, computer science, AI, data science alone. You have to have social sciences, behavioral perspectives, ethical perspectives, and also health, public health, clinical sciences perspectives. So it'll be people, processes, and technology, not technology first. So that's very, very essential.
Thank you. Thank you very much. I think you're quite correct, because as we're speaking about technology here, we need also to look at our policies and legislation and our constitution, because most of the time we've got diseases that are non-communicable. But how are we going to prevent that in terms of technology? Is that not going to violate the rights of individuals when we're using technology? Because sometimes technology can be intercepted, and there's still cyberbullying that can happen there and disorganize the whole good intention that we are trying to do. So it's a lot that we need to look at. Thank you very much.
Thank you. So thank you for the questions and the engagement. That's energized us. And we'll go for the last round. And maybe I'll switch the order around a little bit. Go to you first, Gargi. Your closing remarks, but perhaps you can also speak to, you mentioned the rails, the digital rails, the common rails, the guardrails, to scale innovation, to reinforce inclusiveness. But also you heard the Indonesian presidency, the emphasis on the global health architecture. The last wave of innovation there was when the Global Fund was set up at the turn of the century. So are we ripe for some more innovation at the global health architecture level? And some of these ideas, the FIF and others. So some thoughts there.
Thank you. Thanks again. And I particularly connect with that last question. So, you know, the Gates Foundation is ultimately an investor, a charitable investor. We don't seek a financial return, but social impact return. And through that lens, we often see super exciting individual innovations. What we've come to really look for, the difference between a sort of single innovation and large-scale impact, is a kind of triumvirate of innovation that includes innovation on the product side, on the access side, and on the policymaking side. And it actually requires all three of those things for a bright idea to matter to the people who are hardest to reach. So innovation on the product side, I think we've talked about the many ways in which we're seeing leapfrogging. From my perspective, mRNA technology will transform vaccine development and production well beyond COVID for many of the diseases and situations we care most about. I think we're equally seeing product innovation on the delivery, on the cold chain, on any number of fronts, on the manufacturing processes. We do need to see an equal pace of innovation on the access side. And I would say there, telemedicine, we talked a bit about the national app that my Indonesian colleague spoke about. We are starting to see the potential for kind of point of care innovation, information technology innovation, but the considerations of access are super important. Designing with women in mind, having a sense of privacy in information sharing, taking into account the use case, the customer use case we need to see more of. And finally, innovation on the policymaking side. I think, making sure government, regulators, ministries are ready and have a vision of how digital new technology fits into basic health systems is super important. One of the audience members mentioned drone delivery in Rwanda. We've been pleased to be part of that. Rwanda is piloting a number of health tech innovations. Babel is a telemedicine capability. But the point that often gets missed there is those are integrated in the national health system. And that's how you get to reach and access. It's not the kind of singular innovation on its own. So, if there's one message I would say for all of us, it is that sort of triumvirate of product, access, and policymaking where we need to see innovation. I do think the sequence of G20s led by Indonesia, India, countries where there is both a thriving innovation ecosystem and a forward-leaning policymaking stance and capability, along with that commitment to access, is an opportunity not to be missed. I hope we lean into that and are able to define innovation, access, and policymaking goals on each of those fronts.
Thank you so much. So innovative products, access policy, and opportunity not to be missed. Great takeaways. And Gargi, do look after yourself. Get well soon, but stay with us. And I'll go next to perhaps you, Mrs. Sudan. The interface with the health systems that Gargi mentioned, that so it's not just standalone innovations here and there, but how do we kind of bring them together into more resilient health systems for the future?
So, as I also said earlier, that health system is multi-layered. We have to work through those layers, the primary, secondary, tertiary, the health professionals, down to the frontline workers. So, digital workforce enablement that I spoke about is very, very important. Secondly, process orientation. Because you see, right now, you write a prescription, say on a piece of paper, but if you do it digitally, it helps the patient carry it everywhere. So under this National Digital Health Mission that we have now embarked upon, we are making a unique number is being given for a person to maintain health records. So that should help. And it can be, but then the consent framework, the security, that's what the Indian government is working at, and that's at the heart of the whole concept. So therefore, what I would say is that health systems are very complex. Then again, I also want to highlight once again, we don't have to talk only about health. We have to talk also about wellness, and that's what COVID has taught us. And it's our responsibility too. It's not absence of disease, but it's wellness. It's mental wellness, it's physical wellness, and I would say social wellness then follows. So therefore, how do we connect these dots? A lot of micro work has to be done, Amandeep, I would say, to really make digital health a reality. And we need not be daunted by it. We are doing well. So it will be a process that will take time, but certainly that's the future.
Excellent. Thank you so much. And I want to go to Mark now. Mark, you wrote, the workforce enablement, and then we have 18 million shortage of health workers. In India itself, perhaps 1 million doctors are missing and 7 to 8 million ancillary health workers. So how do we tackle that without scaring people, or any other thoughts that you may have?
Yeah, I mean, I do think, being serious, there is a global shortage of health workers, and of course, European nations have been raiding India and Africa for years. So India and Africa have paid to train health workers, and Europe has made, and the United States. There, at one point, there were more Sierra Leonean doctors practicing in Chicago than in Sierra Leone. So the industrialized countries have made that worse. And I think, therefore, health jobs will change. So it's not so much the idea, and I was being a bit provocative earlier, it's not so much the idea that we'll have lots of jobless doctors wandering around, but the job will change. And that change will be uncomfortable for some people. But I think Mrs. Sudan said earlier something that struck me. We need a culture of benevolence. So we need a culture of benevolence that encourages people to collaborate and to walk boldly into this future that we've talked about. The final point I would say is I think we need to stress the universality of health. So if we keep talking about only the poor and the vulnerable and the marginalized, we run the risk of the middle class feeling, oh, I'm being asked to give up my health services for poor people. That's not the way it is at all. As Mrs. Sudan just said, it has to be a society-wide approach, and we all benefit. If the poor and the marginalized in society are healthier, then all of us benefit, not just economically, but in terms of our own health as well.
Excellent. And you see that in countries like Finland, where social care and health care, digital is helping bring them together. Seamless integration of care, well-being across different silos earlier. Madam Minister, this benevolence, the culture of benevolence, do you see that coming together in countries such as South Africa, India, Indonesia, or was COVID just a kind of one-off story? So academia, universities, private sector, governments working together on, as Gargi was saying, this larger ecosystem enabling.
Thank you very much. Of course, we need to really integrate our work and collaborate more with different countries and learn, because technology is not static. Immediately you master this one, then there's new one on top of that. So we need really to do a strong collaboration with countries like we are the developing country. So we need to make sure that we interact with developed countries and also start to help the underdeveloped countries in terms of accessing the basic technology that we are speaking about, so that we don't leave anyone behind. Thank you.
Great, leaving no one behind. So coalition of the nervously willing. So willing equals. So we're generating a lot of mantras here. Products, access, and policy. I hope someone is taking note. Ambassador, so please help us conclude this discussion by speaking a little more about this diplomatic enabling, because technology can do so much, and policy people have to step in. It's a larger global issue like climate change, like many other challenges we face. So how do you see that, like this coalition, not just because it's no longer a question of the global north and the global south. We all have challenges. Countries of all income levels have been affected by the COVID. So how do you see that coming together?
Well, first, the not so good news that I think multilateralism and international cooperation will be under stress this year, especially after the Ukraine war, right? There are just countries who just don't want to sit on the same table together, don't want to look at each other, and don't want to work together, right? And that's the reality. Confrontation will become hardened, insecurity will become sharper, right? And the space for dialogue and cooperation will become smaller, right? So unfortunately, that's the terrain that we're living in. And that makes it difficult for the G20, for the East Asia Summit, for the Asia-Europe meeting, for the United Nations, for the UN Security Council, everywhere. There's going to be a systemic challenge. So for us in Indonesia, the challenge is, I chaired the largest foreign policy group in Southeast Asia, and we've been very clear in our condemnation of Russia's invasion of Ukraine, very clear about that, and we support the Indonesian government's co-sponsoring a resolution against the invasion in the UN. But having said that, we do think that in the G20, there's a way to do both. There's a way to address the Ukrainian situation, and it must be done, because if G20 doesn't address the Ukrainian situation, people are going to think, what's the use of it? You're not credible then, right? Because it's the most important security and economic issue as well, right? But at the same time, while addressing Ukraine, the G20 must also address issues that it was designed to do. Rebounding the world economy, addressing climate change, which has seen very significant progress since COP26, and also addressing the pandemic, right? Again, what is the formula in terms of attendance is being worked out, but it would be a big pity if the G20 doesn't address Ukraine, which it should, and in fact, I do think it should invite Ukraine to the meeting. And plus, it should not be distracted from reaching some substantive progress on key issues facing the world economy. Because G20 is really about, it's not like the EU where everybody has to, commit to a solution and do coordinated act. G20 is much more loose. Yeah, much more loose. So I think it can be done having some kind of flexible commitment to these issues as long as it delivers progress.
Wise words there. I think it's a loose coalition. There are possibilities on the margins. And as we've discussed in this panel, this is something that concerns not only the large economies, the large countries, but also a lot of the small countries, pioneers such as Rwanda, Ghana, Finland, and others were mentioned. So this should be a coalition of that kind. Perhaps we need not be so nervous. There are negativities to be managed, but there is the future that beckons us, exciting future, prospects offered by data, AI, and digital technologies that are with us even today. We've seen their potential, and we need to exploit that. With the G7, you have Japan, which has a commitment to an advanced society where no one is left behind, but digital technologies are leveraged. So there are all these pioneers out there, and we hope that this discussion helped trigger some thoughts about how this coalition of the nervously willing, a coalition of the equals, can come together and move the world forward. So please join me in thanking our excellent panelists for their contributions. Thank you so much, and enjoy the rest of the conference. Thank you.